So this is the general features of the cranial nerve. We have 12 pair of the cranial nerve, and all of them emerge from the brain stems, except for the olfactory nerve, which resides on the olfactory mucosa, optic nerve, which is formed at the optic disc, and spinal part of the accessory nerve. So all of them is a part of peripheral nervous system, except for the optic nerve, and all of them supply structure in head and neck, and except for the vagus nerve, which is supply for the thoracic and abdominal viscera. So we have three types of cranial nerve, which is probably entirely sensory, entirely motor, and sensory. So this is the brief table that we all can later, and I hope presenter Philip will explain later the sensory motor and the motor sensory. So we also have the functional component of cranial nerve, which is divided into two: sensory function and the motor function. And they have seven different function components. And sensory function is comprised of the general somatic efferent, general visceral efferent, special somatic efferent, and special visceral efferents. So, and for motor function, comprises into three, which is a general somatic efferent, general visceral efferent, and special visceral efferents. So this is the functional components. I will explain in one of the cranial nerve. So the first cranial nerve is the olfactory nerve. It's a purely sensory nerve, and functional component is the somatic visual efferents. For if we look back, somatic visual efferent is the function is the smell and taste. So for this olfactory nerve, it's involved in the smells. And the neuron of the cranial nerve 1 are located in the epithelium of nasal mucosa, while the cell body of other sensory cranial nerve resides in the ganglia. So the pathway that we learned. So the neuron is moved into the olfactory receptor neuron in olfactory mucosa, and then it moved into the olfactory bulb, and then alongside it moved to the primary olfactory cortex along the olfactory tracts. So for the examinations, we ask the patient if they notice any recent change of smells, and we can do this by ask the patient to close their eyes and then occlude one of the nostril and put the stimulus that we want to test on the non-occluded nostril. So we can test with the cup of coffee, we can test with the soap, and for this examination, it was tested with an orange. So we noted the changes, and most of the changes that we know is the cause is anosmia, which is a lost sense of smells. And the most common causes would be head trauma. Head trauma is when it damaged in the ganglion cells. And for the also it can cause by the mucus blockage of the nose, which the odor cannot reach into the neuron receptor. And what other causes is Parkinson's disease and COVID-19. So that's done for the olfactory nerve, and move on to the optic nerve.
Okay. Welcome, hi. Okay, transcribe nanti prepare attendance
already prepared, bro.
Okay, okay, thank you.
Okay. Okay, this is the second cranial nerve, which is about the optic nerve, and it was purely sensory nerve, and the functional component is the somatic. It is a somatic. Special somatic efferents. So about the special somatic efferent, it's involved in the vision. For the cranial nerve 2, it's involved in the general function of the visions. And it's a part of the central nervous system. It's the only cranial nerve that part of the central nervous system. And it's formed by the ganglion, by axon of the ganglion cell in dentina, and it's surrounded by the meninges and myelinated oligodendrocytes. So this is the visual pathway. The neuron move around the retina, and then as you can see, it moves around the optic nerve, and then through the optic chiasm, and move to the optic tracts, and to the lateral geniculate body, and alongside to optic radiation, and lastly it move into the primary visual cortex. which is primary visual cortex, is the Brodmann of 17. So this is a common cause of lesion occur. Let's say in the first, which is if a lesion occur in the optic nerve, like optic neuropathy, we will have a ipsilateral monoocular visual loss, which is if we have a lesion on the left optic nerve, it causes the monocular vision loss in the left eyes. So secondly, we learn about the lesion at the optic chiasm. So what the most common lesion of the optic chiasm is pituitary microadenoma, which is cause the compression of the around the optic chiasm, and it will cause the bitemporal hemianopia. And alongside that is we have a lesion in the optic tract, and in the optic tract, it's we will have a contralateral homonymous hemianopia, which is if we have a lesion at the left optic tract, we will have a problem on the right side of a lesion of both eyes. That's why it's a contralateral. So other cases is the lesion at the parietal upper optic radiation. It's also a contralateral, but if it involves parietal upper, it will cause the only homonymous inferior in quadrantropia. But if it involves the lesion at the temporal lower optic radiation, it involves the homonymous and superior quadrantropia. So the last one is the lesion at the occipital visual cortex, which is will cause the contralateral homonymous hemianopia. But the difference between the lesion at the optic tracts, it's have a macula sparring, which is central visual field is preserved. So this is the cranial nerve examination, second cranial nerve examination that we can test. We can test for the visual acuity test using a standard Snellen chart. So we ask the patient to stand a 6 meter from the Snellen charts, and we test them by cover the one eye and ask the patient to read from the highest line to the lowest line as they're possible. So if the patient are wearing the glasses, we should ask them to keep them wearing glasses. And if the patient the lowest line should patient able to read is 6/6 in the metric form. And if the patients not achieve the 6/6, we can ask them to wear the pinhole to see if they improve any visions. And after that, we repeat the steps in the other eyes to see the other eye visual acuity. So this is the cause of the decrease in the visual acuity. So if we learned already in the ophthalmology that what's the bilateral blindness of the rapid onset on the both eye, because the both eye is bilateral. So the most common for the rapid onset is the infarction, and it's all occur in the occipital lobes and occipital trauma. And also in the optic nerve damage, we see the bilateral optic nerve damage with both the optic nerve is damaged lah. And what's the common for the bilateral blindness of the gradual onset, which is progress slowly. And what we already learned in the ophthalmology is the cataract, glaucoma, diabetic retinopathy, and chiasmo compressions. So this is sudden, lastly is the sudden blindness in one eye. And if one eye is only involved one optic nerve, so usually it can caused by the retinal artery event occlusion, optic neuropathy, and optic neuritis. So other tests for the optic nerve we do is the visual field confrontation test. What we do, we sit with the patient together 1 meter apart and ask patient to cover one of their eye with the hand. And after that, we mirror the patient. We cover if the patient cover the left eye, we cover our right eye, just mirror the patients, and ask the patient to focus part on our face, for example, our nose. And ask them to move their heads during the assessment. And yeah, we should also do the same, which is not too much. And ask for the central, if there any visual field loss in central visual field loss, if they see our face, and note ask them that if they see our face or not, or any distortion in our face. Then later on, we should position our finger at the equal distance between us and patient, and we compare we compare our visual field and patient visual field, but we have to make sure our visual field is okay, is normal lah, to do this test. And after we compare, we move slowly into the center and ask the patient whether they see it. So if we able to see the target, but the patient cannot, this is suggest that patient have a reduced in visual field. And then after that, we repeat in the other eyes. Subsequently, we mirror to that. And for the other optic nerve examination is the light reflex. So we have 3 light reflex that we want to assess. The first one is the direct pupillary reflex. Is just we shine on the left that we want to test, and we see the pupillary constrictions. And other is the consensual pupillary reflex, which is once again we shine on the, let's say we shine on the left eye, but we observe the right eye, whether if the contrary, it should be constrict as well. So other test is the swinging light test, which is to check the RAPD. And this one, if you can see on the picture, on the left side is the normal one. So when we not tested, it should be dilated, but when we shown the light, let's say on the right eye, it should be constricted, and the left should be also constricted. And when we shine back to the right, it should be also constricted. So this is for the second and the middle line. You'll see the RAPD positive is on the left eye. You see the left eye have a problem with the optic neuropathy. So on the right eye, when we shown on the right eye, the optic nerve is intact, so it should be constrict on both eyes, which is direct and concentric pupillary reflex should be intact. So both eyes should be constrict. So when we swing back to the left eye, it will cause dilation because of the optic neuropathy on the left eye. And when we swing back, it should be constrict back. It should be constrict because of the right eye optic nerve is intact. So the last one is I want to talk about the reverse RAPD, which is only we test for the non-reactive pupils, because for this one, the left eye is have a optic neuropathy, but the problem is a non-reactive, so we cannot do the RAPD test because when we check on the left eye, it's not dilated. So what we do when we swing from the right to the left, we check the other eyes. Let's say from the right eye, we swing to the left eye, but from the left eye, we see the dilation of the right eye, here. That's cause the reverse called the reverse RAPD, and is the RAPD positive. Okay. Last one for the test for the optic nerve is the color vision test. Is ask them to close one of their eyes and ask the patients to read the number on the Ishihara plates. So usually on the first plate, it suggests the test plate, which it did not test the color vision, but instead it just tests the contrast and sensitivity. So is a patient unable to read the test plate, we should document this. So is patient able to read the test plate, we should move the all Ishihara plate and ask the patients to identify the number on each. So like this picture, patients should be able to identify the number. So when the test is complete, we should document it correctly and recommend it. So and test it, and after that we test it on the other eye. So move on to the next cranial nerve, and for this cranial nerve, I will talk about the cranial nerve that cranial 3, 4, and 6. So the next presenter will continue on the cranial 5. Because cranial 3, 4, and 6, it supply the extraocular muscles. So first one is the oculomotor nerve, with the cranial 3. It's a purely motor nerve, and it's involved in 2 types of fiber, which is the general somatic efferent and general visceral efferents. For general somatic, it's innervate in the smooth muscles, and for general visceral efferents, it's innervate in the in the general visceral efferent innervate in the smooth muscle, and general somatic efferent innervate in the skeletal muscles. So the function of oculomotor nerve, it's responsible for the movement of the eyeballs, pupil constriction, and accommodations. So what's the function? So as we know, it's supply all the extraocular muscle except superior oblique and lateral rectus. So it's involved in the movement of the eyeballs. And it also supply the ciliary muscle, which is changes in thickness to focus of the lens. As you can see in the picture here, it's when the suspensary ligament taut, the lens it thins and it can focus on the distant object as it becomes thin. But when the ciliary muscle fibers contract, the suspensary ligament will be relaxed and will cause the lens to be fixed and focus into the closer visions. Okay, and the last one for the function, it's involved in the constrictor pupillae muscles. So I already highlight here. On the inside is the constrictor pupillae, and the outward of the eye pupil is the dilator pupillae. So for this one, it's involved in the pupil constricts to as the circular muscle of the iris contracts. So yes, oculomotor nerve also supply the levator palpebrae superioris, which is involved in the elevate upper eyelid, and it's involved in, it have two parts, levator palpebrae superioris, which is voluntary part and involuntary part. And for this one, it was supplied by the oculomotor nerve and sympathetic, which is an involuntary part. So this is the course, and usually we know that it will emerge from middle aspect of post cerebri of the midbrain. So this is the oculomotor nerve, and you can see here on the anterior side, it's called the part of the here is called the post cerebri, and as they emerge, it passes between the posterior cerebral and superior cerebellar arteries. You can see on the second picture. And then it pass in the lateral wall of the cavernous sinus. And yeah, and here you can see the picture that it passes into the lateral wall of the cavernous sinus, and it's enter the orbit through the superior orbital fascias. Then it divides into two. It's divided into two, which is the superior division and inferior division. So superior division, it's supply the superior rectus and levator palpebrae superioris, and inferior division, it's supply the medial rectus, inferior rectus, and inferior obliques. So it also have a nucleus, which is two nuclei of the cranial nerve. It's located in the midbrain at the level of superior colliculus. So two nuclei of the cranial oculomotor nerve, which is the oculomotor nucleus, is involved in GSE and provide motor fiber to extraocular muscles and levator palpebrae superioris, and which is located in the cerebral aqueduct. And for the lateral side, we have the Eddingworth nucleus, which provide parasympathetic innervation to the sphincter pupillae and ciliary muscles. So for the clinical settings, if we have a oculomotor nerve palsy, you have a ptosis, which is a dropping of the upper eyelid, and it will due to the paralysis of the levator palpebrae superioris. And we can also have the squints. For this case, it's caused the right eye exotropia, which is medial rectus is paralyzed, and it can cause the exotropia. And the last picture we see is dilated pupil is due to unopposed action of the sympathetic nerve. Patient also can loss of the light reflex, which is paralysis of the constrictor pupillae muscles, and loss of accumulation, which is patient cannot focus, which is due to the paralysis of the ciliary muscles. So next, I will talk about the trochlear nerve, which is it's all entirely motor nerve, and its functional component is the general somatic efferents. It's the smallest cranial nerve and has the greatest intracranial length, and the only cranial nerve that exists from posterior aspect of the brainstem. It supplies the supraoblique muscles, and supraoblique muscle is inside eyeball, function in the inside of the eyeball and move the eyeball downwards. So this is the curve of the trochlear nerve. You see, it's emerged from the posterior aspect of the midbrain, just below the inferior colliculus. So like I thought in the oculomotor nerve, this is the inferior colliculus, and the upper part is the superior collicular. And then it curves around the cerebral peduncle. So as you can see in my arrow here, this is the cerebral peduncle, which is it's going to the anterior side of the brainstem. And then it's into the medial cranial fossa in the lateral wall of the cavernous sinus. So it just posterior to the oculomotor nerve, You see the small yellow color here. It is posterior to the oculomotor nerve. And after that, it's into the orbit through the superficial orbital fissures. So this is the clinical setting. We have a trochlear nerve palsy. We have a scenario of our right eye will be exalted. Okay, let's see the normal eye first. When the normal eye, we tilt our head to the left, our both eye will rotate to opposite direction. This is our right eye will be exalted and the left eye will be introct. But if we have a cranial nerve trochlear nerve palsy, our right eye will be exalted and slightly elevated, which is caused the diplopia. And to compensate that, we see the patient will take the head to the left. Just he want to compensate the right eye that have the trochlear nerve palsy. So that's why we see the trochlear nerve palsy. Someone with trochlear nerve palsy will walk with the head tilted. So okay, the last cranial nerve I'll present is the abducens nerve palsy. It's also entirely motor nerve, and it's also component of the genosomatic efferents. And for this abducens nerve, it supply the lateral rectus, which is the move eye to the lateral side. So what's the cause? It's emerged from the quatermillary junction between the pyramid and pons, and it passes through the cavernous sinus, which is lying introlateral into the ICA, internal carotid artery. And after that, it's into the orbit through the supraorbital fissure, but this time it's within tendinous ring, which is to supply the lateral rectus. So it have a nucleus, which is called the abducens nucleus, which is located in the lower part of pons, which is close to the midline and beneath the floor of pons ventricles. It just beneath the facial colliculus, and the fiber pass anteriorly through the pons and emerge in the groove between the pons and medulla. That's why it's emerged between the pontomedullary junctions. So this is the part of the abducens nerve palsy. You will see our eye will move medially. If someone will present the abducens nerve palsy, we have the right eye or left eye esotropia. And when we tested the extraocular muscle movement, it cannot move the eye laterally beyond the midpoint. And from that, we know that the patient have the paralysis of the lateral rectus. So here, from the examination of the cranial nerve, the extraocular muscle, which is we inspect for any ptosis, any squints, and any eye movement. And for that, we ask the patient for we hold our finger, which is approximately 30 cm in front of the patient, then ask the patient to focus on it. And we look our eyes, we'll focus on the patient eyes to see any restriction or any deviation for the abnormal movement. And from there also, we can ask the patients. We can ask the patient about are there any double visions or any pains. And after that, we move our finger through the various X of pattern of H. So from movement pattern of H, we see any restrictions and any nystagmus involved. To see what cranial nerve lesion is involved if patient has restrictions. So let's say a patient has a diplopia, we ask the patient whether he see the diplopia is side by side or above one another. If side by side, it's usually caused by lesion on the lateral or medial rectus, and if one above another, it's usually problem on the oblique superior and inferior rectus. And we ask the patient to cover one eye if noted the image is disappeared. If cover one eye and the affected eye, we call it monoocular diplopia, which is the diplopia disappear when we cover the affected eye. But when we cover either one of the eye, it's called binoocular diplopia, which is either we cover one of the eye, the diplopia is disappear. For the lastly is we test for the accommodation test, which is our test for the oculomotor nerve. And we ask the patients, first of all, to focus on the distant object, like the clock on the wall or light of switch. So after that, we place a pen, which is approximately 20 to 30 cm in front of the eyes, and ask them to switch from looking at the distant object to the nearby pen. From that, we observe the pupils and we see if there are any constrictions and convergence bilaterally. From that, we know if the patient have problems in the accommodation reflex. So that's from me. Next presenter. We continue.
Assalamualaikum and good afternoon to Prof. Hafiz and also my fellow friends. Okay, my name is Maisara and I will continue with the next cranial nerve number 5 or trigeminal nerve. Okay, moving on to the next slide. So the cranial nerve number 5, the trigeminal nerve, is a type of mixed nerve which involve both sensory and also the motor root. And it's emerged from the lateral aspect of the pons as a small motor root and also the large sensory root. As you can see, based on the picture provided, there is at the pons, at the lateral aspect of the pons, there is a small root and also the large roots. So the large one is the sensory and the smaller one is the motor root. And the trigeminal nerve subdivided into 3, which are ophthalmic nerve V1, maxillary nerve V2, and also the mandibular nerve V3. Next. Okay, so the function of the trigeminal nerve for V1, it carries the sensory information from the scalp and the forehead, from the nose, upper eyelid, conjunctiva, and also the cornea of the eye. Whereas for the maxillary nerve, the V2, it carries the sensory information from the lower eyelid, cheek, nares, upper lip, upper teeth, and also gums. Whereas for the mandibular nerve, the V3, it carries sensory from the chin, jaw, lower lip, mouth, lower teeth, and also gums. And it also carry motor function from the muscle of mastication, which involve temporalis muscle, masseter muscle, medial and also lateral pterygoid muscle, tensor tympani, tensor veli palatini, mylohyoid, and also the digastric muscles. Moving on to the root and also the course of the trigeminal nerve. So the nerve leaves the anterior aspect of the pons and then it passes forward out of the posterior cranial fossa. And then it will rest on the petrous part of the temporal bone in the middle cranial fossa as the picture provided. It shows that the cranial nerve is rest on the petrous part of the temporal bone. And then the large sensory root will expand to form the trigeminal ganglion that located in the trigeminal cave, and then it will be subdivided into the ophthalmic, maxillary, and also the mandibular nerve. Next, we move on to the ophthalmic nerve, the B1. So the course of the ophthalmic nerve, it passed forward in the lateral wall of the cavernous sinus, and then it will enters the orbit through the superior orbital fissure, and then it will be further divided into 3 branches, which are frontal nerve, lacrimal nerve, and also nasociliary nerve. So the frontal nerve, it provides sensation to the forehead, frontal sinus, and also skin of the upper eyelid. Whereas for the lacrimal nerve, it provides the sensation to the lacrimal gland. And the nasociliary nerve, it provides the sensory to the cornea, eyelids, and also the conjunctiva. Next, for the maxillary nerve, it passes forward in the lateral wall of cavernous sinus and it will leave the cranial cavity through foramen of tandem. As you can see, the picture provided, there is the red circle, so it shows that it is the foramen of tandem. So then the maxillary nerve will enter the pterygopalatine fossa and it enter orbit through the inferior orbital fissure, and then it will continue as the infraorbital nerve. For the V3, the mandibular nerve, the sensory fibers of the mandibular nerve coming on from the trigeminal ganglion, whereas the motor fibers arise from pons. These fibers will fuse below the foramen ovale to form trunk of the mandibular nerve. You can see the picture provided shows the trunk of the mandibular nerve. So then it will enters the infratemporal fossa and divides into the anterior and the posterior division. Okay, next. So to assess the sensory for the trigeminal nerve, we do the light touch and also the pinprick sensation. So we do the light touch and also the pinprick sensation at the forehead, cheek, and also the lower jaw. So the forehead, we measure at the V1 sensory for the sensation, and also the cheek for V2 and also V3 for at the lower jaw. And the step is we introduce ourselves to the patient, and also first of all we need to demonstrate first before we test to the patient. So demonstrate on the patient's sternum and tell patient that how we are going to do this test. We demonstrate the light touch and also the pin prick sensation on their sternum so that they know what it feels like. And then we ask patient to close their eyes, and then we start to do the light touch and also pin prick on the forehead, cheek, and lower jaw. And we need to compare both right and left side of the forehead, of the cheek, and also of the lower jaw. For the motor assessment, we first we need to inspect the temporalis and masseter muscles for evidence of any muscle wasting, and then we palpate the masseter muscle bilaterally while asking patient to clench their teeth. So we do this to assess the muscle bulk, and then we ask patient to open their mouth while we apply the resistance below the jaw to assess for the lateral pterygoid muscle. So if patient unable to open the jaw against the resistance, or if there is any deviation of the jaw, so this indicate there is trigeminal nerve palsy. Next, okay, for the reflex, for the trigeminal nerve, we need to test for the reflex. So we have two reflexes, jaw jerk reflex and also the corneal reflex. So for the jaw jerk reflex, we place the finger horizontally as shown in the picture below, and then we do a gentle tap on our finger with tendon hammer. And then in a healthy individuals, there will be absent or just a little reflex of the jaw jerk. But if a patient has brisk jaw jerk reflex, so this indicates that patient had upper motor neuron lesions. For corneal reflex, we test for corneal reflex by using the cotton wool. We use the cotton wool to touch the patient's cornea. So we, as the picture shows below, we just use the tips of the cotton wool, just a little bit, and then touch the patient's cornea to see whether there is blinking response or not. So in the healthy individuals, there will be direct and consensual blinking. But if there is absence of blinking response, so this may suggest that there is pathology involved either trigeminal or facial nerve. So deletion of the trigeminal nerve, deletion to the trigeminal nerve can result in the loss of ability to appreciate general sensation, include touch, pain, or tremor in the face, the paralysis of muscle of mastication, with deviation of the mandible to the same side of the lesion, and also there will be reduced jaw strength. And last but not least, there will be loss of corneal reflex and also the jaw reflex. Next, for the cranial nerve number 7, the facial nerve. This nerve is a type of mixed nerve which involves both sensory and also motor, and the nerve emerge from the lateral aspect of the pontomedullary junction as the picture provided. And the general function of the facial nerve is to supply muscles of expression, salivary gland, lacrimal gland, and also the taste from tongue, the anterior two-thirds of the tongue. The cause of the facial nerve, the motor and sensory roots emerge from the lateral aspect of pontomedullary junction, and it will pass laterally in the posterior cranial fossa together with the cranial nerve number 8, which is the vestibulocochlear nerve. And this facial nerve will enter internal acoustic meatus, and then it will enter the facial canal and emerge from the stylomastoid foramen. And then it will pass through the parotid gland. Moving on to the next slide, there is a picture. Okay, the picture on your left side shows that the course of the facial nerve. So first, it will enter the internal acoustic meatus, and then it will pass through the stylomastoid foramen, and then it will pass through the parotid gland and divided into 5 terminal branches. So these 5 terminal branches of the facial nerve include the temporal branch, zygomatic, buccal, mandibular, and also cervical. Next. Uh, so to test for the sensory for the facial nerve, for sensory assessment, we just ask patient if they have noticed any recent changes in the sense of taste, because the facial nerve provide the taste from the anterior two-third of the tongue, carries the sensation from anterior two-third of the tongue. For the motor assessment, first we ask the patient if he or she notice any hearing changes, because the paralysis of the stapedius muscle can result in the hyperacusis, which is the oversensitive to the sounds. And then we inspect for any facial asymmetry, such as the forehead wrinkles, the nasolabial folds, or the angles of the mouth. And then we assess for the facial movement. Next, can we move to the next slide? Okay. So to assess for the facial movement, the first picture from your left on the top shows that we ask patient to raise the eyebrows. So this is to assess the frontalis muscle. And the second picture, we ask patient to tightly shut their eyes, and then we try to open up. This to test for the orbicular oculi muscle. And then third picture, we ask patient to blow out the cheeks to test for the orbicularis oris. And then we ask patient to purse lips to test for the orbicularis oris and also the buccinator muscle. And last but not least, we ask patient to smile and show their teeth to test for the levator anguli oris and also the zygomaticus major muscle. So the facial nerve palsy can be caused by both upper and also the lower motor neuron lesions. So for the lower motor neuron lesion, it affects both upper and also lower part of the face, whereas for the upper motor neuron lesion, it only affects the lower part of the face. So this is because as you can see on the picture provided, when the upper part of the face receive the bilateral innervation, which is the contralateral and also the ipsilateral from the cortex. So you can see the picture number B, there is supranuclear lesion. Even though there is a supranuclear lesion at the cortex, it will not be, the upper part of the face will not be affected because it receives the bilateral innervation. But it will affect the lower part of the face because the lower part of the face only receive contralateral innervation. But when there is a lower motor neuron lesion, as shows in the picture number A, there is the lower motor neuron lesion and affect both upper and lower part of the face. So the lower motor neuron lesion commonly seen, the commonly case is Bell's palsy, whereas for the upper motor neuron lesion, the commonly case is the stroke. Next. Okay, so the lesion of the facial nerve, when there is lesion of the facial nerve, we can observe there is loss of wrinkle on the forehead because of the paralysis of the frontal muscle. There will be inability to close the eyelids because of the paralysis of the orbicularis oculi. There will be drooping of corner of the mouth with drooling of saliva because of the paralysis of the orbicularis oris. And there will be absence of nasolabial folds. And last but not least, there will be accumulation of the food in vestibule of mouth and also the inability to inflate the cheek because of the paralysis of buccinator muscle. Next, moving on to the vestibulocochlear nerve. So the vestibulocochlear nerve is a sensory nerve, and the origin for the vestibular nerve is it arises from the bipolar neurons in the vestibular ganglion, whereas for the cochlear nerve, it arises from the bipolar neurons in the spiral ganglion. But both nerves, both vestibular and cochlear, are wrapped together by a common connective tissue sheath. And the function of the vestibular nerve is it carries the sense of equilibrium, include the position and also the movement of the head, whereas for the cochlear nerve, it is for hearing. It carries sound impulse from the cochlea to cochlear nuclei in the brainstem. So the course of the vestibular and cochlear nerve, the vestibular nerve, it begins in the vestibular ganglion, whereas for the cochlear nerve, it begins at the spiral ganglion, and both of these nerves will exit the internal acoustic meatus and enter the posterior cranial fossa and pass the cerebellopontine angle to reach the brainstem. And both of these nerves will enter the brainstem at the pontomedullary junction. And for the cochlear nerve, it will branches into two. The one fiber will goes to the posterior cochlear nucleus, whereas the other one goes to the anterior cochlear nucleus. For the vestibular nerve, it will be divided into long descending fibers and also the short ascending fibers before it enters the vestibular nuclei. And then these two of them, the cochlear nerve and also the vestibular nerve, will be terminated at their respective nuclei. So the damage to the vestibular nerve will cause the disequilibrium, the vertigo, and also the nystagmus. Whereas for the damage to the cochlear nerve will cause the sensorineural deafness and also tinnitus in the patient. So to assess for the vestibular cochlear nerve, for hearing testing, we do the whispered voice test, Weber's test, and also the Rennie's test. For the vestibular function test, we do the Unterberger's test or turning test and head thrust test. So for the whispered voice test, we stand behind the patient and start testing with the mouth about 15 cm from the patient's ear. And then we do the masking by rubbing the triggers of the patient's ear. And then we ask patient to repeat a combination of multi-syllable number and words. For example, we give 5, 2, 8 and ask patient to repeat after we mention that. And then we start with a normal speaking voice to confirm that the patient is able to understand the test. And then we start to lower down the voice to a clear whisper. And then we repeat the test at arm's length from the patient's ear. So people with normal hearing can repeat words whispered at 60 cm. For Weber's test, we use 512 Hz of the tuning fork because of it has a balanced time of decay and vibration. And then we strike the prongs of the tuning fork against hard surface to make it vibrate. And then we place the tuning fork in the middle of patient's forehead. And then ask the patient, where do you hear the sound? Is it lateralized to both ears, or is it in the middle, or is it lateralized to which part of the ears, which ears? So for normal individual, the noise will be heard in the middle or equally in both ears. For conductive hearing loss, it will be lateralized to the affected ear, whereas in the sensorineural hearing loss, it will lateralize to the unaffected ear. For Rennie test, same, we strike the prongs of tuning fork against hard surface, and then we place the tuning fork on the mastoid process to test for the bone conduction and ask the patient if he or she can hear the sound. And then we change the position in which we put the tuning fork in front of the external auditory meatus to test for the air conduction. So the healthy individuals or patient with the sensorineural hearing loss will have air conduction is better than bone conduction, or we call it as Rennie positive. Whereas for the patient with conductive hearing loss, the result will be Rennie negative, in which the bone conduction is better than air conduction. So these are the causes of the conductive hearing loss and also the sensorineural hearing loss for you to read later. Okay, next. Okay, so for to test for the vestibular function, we do the Unterberger or turning test, or in other words, it also can be called as Fukuda test, and also the head thrust test. So for the Fukuda test, actually I provide 2 links below for you to watch later regarding the Fukuda test and also the head thrust test. So for the Fukuda test, we ask patient to march with their arms outstretched and also the eyes closed. So we observe whether during the marching, either a patient still in the same position or turns either towards to the left or to the right, because in a normal position, in a normal person, the person should be remains in the same position during the marching. But if the person have vestibular lesion, he or she will turn towards either the right or the left, based on the side of the lesion lah. And then for the head thrust test, first of all, for the head thrust test, before we proceed with this test, we need to ask a patient if he or she has any neck problems. Because if a patient has any neck problems, we cannot proceed with the head thrust test because it involves the turning of the patient's head to each side. And then in a normal person, there will be ocular fixation. Okay, so for the head thrust test, after this, you can watch the video that the link that I provide for better understanding. I think that's all from me. I pass to the next presenter.
Okay, Assalamualaikum and good afternoon to Prof and my fellow friends. So I will present for cranial nerve 9, 10, 11 and 12. So I will start with the cranial nerve 9, which is glossopharyngeal nerve. Okay, next. So this is the nuclei and distribution of glossopharyngeal nerve. Glossopharyngeal nerve is a mixed nerve which have motor, sensory and parasympathetic. So for motor, it supplies stylopharyngeal muscle, originate from nucleus ambiguous. For sensory part of glossopharyngeal nerve, it supplies taste from posterior one-third of tongue, carotid body and carotid sinus, and also general sensation from posterior one-third of tongue, palatine tonsil, oropharynx, auditory tube, middle ear, and is originate from nucleus of tractus solitarius and spinal nucleus of trigeminal nucleus, cranial nerve number 5. And then for parasympathetic part, it supply parotid gland and it is originate from inferior salivatory nucleus. Okay, next slide. So we go for the glossopharyngeal course. It emerged from posterolateral sulcus between olive and inferior cerebral peduncle. And then it passed laterally in posterior cranial fossa and then exits skull through jugular foramen and then it descends in upper part of neck to reach posterior border of stylopharyngeal muscle. Here it supplies the stylopharyngeal muscle and then it passes forward between superior and middle constrictor muscle to supply pharynx and tongue. So next is the glossopharyngeal nerve branches. We have 6 branches. First, lingual, tympanic, tonsillar, muscular, carotid and pharyngeal branches of glossopharyngeal nerve. So next slide. So this slide is about the glossopharyngeal nerve clinical examination. It is tested by touching the posterior wall of the oropharynx. This causes reflex, contraction of the pharynx and elevation of uvula, which can be called as gap reflex. Usually, this cranial nerve 9 is tested together with cranial nerve 10 as afferent link of this reflex is from cranial nerve 9 and efferent link is from cranial nerve 10. Then lesion of the glossopharyngeal nerve may cause loss of general sensation and taste from posterior one-third of tongue, loss of general sensation from oropharynx, soft palate and palatal tonsil, loss of gap reflex and also loss of salivation from parotid gland which cause dry mouth. Okay, next. So next we move to cranial nerve 10 which is vagus nerve. Okay, next for the cranial nerve 10, it also a mixed nerve which has 3 parts, motor, sensory and parasympathetic. For motor, it supplies the muscle of pharynx except for stylopharyngeus. It supplies muscle of the soft palate except for tensor villi palatini and also it supplies intrinsic muscle of larynx and it's originate from nucleus ambiguous. For sensory part, it supplies taste from epiglottis and root of tongue. It supplies visceral sensation from thoracic and abdominal viscera, aortic body chemoreceptor and aortic arch baroreceptor. Also supply general sensation from external ear, dura of posterior cranial fossa and mucosa of larynx and laryngopharynx. For the parasympathetic, it supplies thoracic viscera, heart and lung and also abdominal viscera. So for vagus nerve, it is the only nerve that supplies the abdominal part. So for the nuclei are from the nucleus ambiguous, solitary nucleus, spinal nucleus of trigeminal nerve, and for parasympathetic, it originates from dorsal nucleus of vagus nerve. Next slide. Okay, for the vagus nerve course, it emerged at posterolateral sulcus between olive and inferior cerebral peduncle, which is inferior to cranial nerve 9. It passed laterally through posterior cranial fossa and exit through the same with cranial nerve 9, which is the true jugular foramen. Then it fused with cranial root of accessory nerve, which is cranial nerve 11, below the inferior ganglion, and then it descends in the neck within carotid sheath. Okay, for in the carotid sheath, it is together with internal jugular vein and communicating carotid artery. Okay, next slide. So this is the course in the neck, which is the left and right vagus nerve. Okay, we go one by one. Next slide. So for the right vagus nerve, it enters thorax and pass posterior to the root of right lung and contribute to pulmonary plexus. And then it pass on posterior surface of esophagus and contribute to esophageal plexus. And next, it enter abdomen via the esophageal opening of diaphragm. Now, vagus nerve is called as posterior vagal trunk. It pass on posterior surface of stomach. So posterior surface of stomach is highlighted here because we need to differentiate between the right and left vagus nerve. Okay, next. So this is the left vagus nerve in thorax. Basically, it is same with right vagus nerve, but it pass anterior to the surface of stomach. That is the difference between the right and left vagus nerve. Okay, next is the vagus nerve branches. It has 10 branches: meningeal, auricular, carotid, pharyngeal, cardiac branches, superior laryngeal, recurrent laryngeal, pulmonary branches, esophageal branches, and also anterior and posterior vagal trunk. Okay, next. So for the clinical examination of vagus nerve, as I stated earlier that vagus nerve is often examined together with cranial nerve 9, that we look for uvular deviation and gap reflex. So the effect of the complete lesion unilateral, it will deviate the uvula towards the normal side. So based on the picture, the uvula will deviate to the normal side. So normal side is the left side. So lesion is at the right side. Second is absence of gap reflex. As we know, vagus nerve is efferent nerve or gap reflex. And the third one is hoarseness of voice. Fourth is nasal voice. Fifth, nasal regurgitation of food. And lastly is difficulty in swallowing. For vocal cord paralysis, if only one nerve is damaged, phonation is possible. But if both recurrent laryngeal nerves are damaged, both vocal cord will lie in pharamidal position, and then this will cause loss of phonation and also result in dyspnea and stridor. Okay, next. Okay, next is about cranial nerve 11, which is accessory nerve. For cranial nerve 11, it is purely motor. It is not same with cranial nerve before, which is mixed nerve. It is purely motor, so the functional component is the special vis right frame. Cranial nerve 11 has two roots, cranial root and spinal root, where cranial root originate from nucleus ambiguous, while spinal root originate from accessory nucleus in anterior great horn of C1 to C5 spinal segment. Cranial root is considered as a part of vagus nerve because it is fused with vagus nerve later, and it distributes in pharyngeal and recurrent laryngeal branches of the vagus nerve to supply muscle of the soft palate, pharynx, and larynx. For spinal root, it supplies trapezius and sternocleidomastoid muscle. Next is the cranial nerve. Next, this is the course of the cranial root of the cranial nerve 11. It emerged from lateral part of medulla between olive and inferior cerebral peduncle. Later will unite with spinal root for a short distance, then exit cranial cavity via the jugular foramen. The two roots separates and the cranial nerve root fuse with vagus nerve. And next is the spinal root of cranial nerve 11. Spinal root emerge from the spinal cord from C1 to C5, and then it ascends and enters cranial cavity through foramen magnum. Here it fused with cranial root for a short distance, while then separate again. Then it exits cranial cavity via the jugular foramen and descend in the neck and enter the sternocleidomastoid muscle and supply it. And then it also crossed the posterior triangle of the neck and it will supply for the trapezius muscle. So next is the accessory muscle clinical examination. Basically, we had discussed about spinal root that supply the sternocleidomastoid and trapezius muscle. First, we go for action of sternocleidomastoid muscle, which is the contraction of one side will rotate the head to opposite side, while contraction of both sides will cause the flexion of the neck. So if lesion occur, it will result in weakness during turning head to opposite side. So what we do to examine, we ask patient to turn their head against the resistance. So for the trapezius muscle, the action of trapezius muscle is to elevate the shoulder, making of shrug shoulder and retraction of shoulder. If lesion happen, it will result in dropping of shoulder, which is inability to shrug the shoulder. So what we do to examine is we put both our hand on the shoulder patient and then we apply pressure and ask patient to move against the resistance. Okay, next. So for the last cranial nerve, which is the cranial nerve 12, hypoglossal nerve. Next, for the nuclei and distribution of cranial nerve 12, it is also purely motor nerve. The functional component is general somatic efferent. Its function is to supply all intrinsic and extrinsic muscle of the tongue except for palatoglossal muscle that already supplied by vagus nerve. It is originated from hypoglossal nucleus. And before that, the table, this one show for the intrinsic and extrinsic muscle of the tongue. Okay, next. So this is the course of the hypoglossal nerve. It emerged from the anterolateral sulcus between pyramid and olive, and then it passed through posterior cranial fossa and leave cranial cavity through hypoglossal canal. Then it descends in the neck until it reaches lower border of posterior belly of digastric muscle, where it turn forward and cross internal and external carotid artery. Then it pass on lateral surface of hyoglossus muscle and then send branches to supply muscle of the tongue. Okay, next. So for the clinical examination of cranial nerve 12, we ask patient to protrude their tongue. So unilateral lesion to hypoglossal nerve will cause paralysis of tongue on the same side of lesion. So based on the picture, the tongue is deviated to left, so the lesion is at the left. When the tongue is protruded, it deviated to paralysis side because of an opposed action of muscle of opposite side. Taste and tactile sensation are unaffected, but speaking is slow and swallowing is different. So I think that's all for cranial 1 until to cranial nerve 12. Thank you.
So any question? No question, eh?
I think no question, Doctor.
Okay, any question, give you some brief